Right now, I bet you're busy taking care of everyone else in your life. The mental load of keeping up with work and family is exhausting. When was the last time you took care of yourself? October is Breast Cancer Awareness Month, and I'm asking you to put your health first. Take a moment to talk to your doctor about whether it's time for your mammogram or other cancer screenings.
You heard her, y'all. That was First Lady Jill Biden encouraging women to talk to their doctors to plan out their prevention and screening for breast cancer. It's important. Breast cancer is the second most common cancer in women after skin cancer. The National Cancer Institute, NCI, estimates that there will be over 310,000 new cases of breast cancer in 2024, and that approximately 13.1% of women will be diagnosed with breast cancer at some point in their lifetime. And while breast cancer occurs mainly in women, men can get it too. Many people don't realize, but men have breast tissue and can also develop breast cancer. Fortunately, researchers have been pioneering the future of how we prevent, detect, treat, and survive breast cancer. Today, in honor of Breast Cancer Awareness Month, we're honing in on prevention, what we can do to prevent breast cancer, and how research is evolving to help us with early detection and prevention. This is Empathy Affect, Forsmarsh Media's podcast that explores the human side of government. I'm Melissa Szynski, and today we're joined by Dr. Brandy Heckman-Stoddard, who leads the Breast and Gynecological Cancer Research Group within NCI's Division of Cancer Prevention. She'll walk us through NCI's role in researching early breast cancer prevention and how prevention research leads to steps we can take to reduce our risk and stay healthy. Dr. Heckman-Stoddard, it's so lovely to have you on Empathy Affect. I know that breast cancer awareness and prevention are both very important, so I'm thrilled that you're joining us.
I am so excited to be here with you today. Thank you so much for having me.
Of course. So you've been the chief of the Breast and Gynecological Cancer Research Group in NCI's Division of Cancer Prevention for the last 6 years. But I understand that you've been with NCI since you were a Cancer Prevention Fellow in 2009. So what drew you to cancer prevention in the first place? And how have you seen cancer prevention science advance over the years you've spent at NCI?
Thank you. So I knew early on that I wanted to be a scientist, but I initially thought I wanted to be a marine biologist, and I went to University of Delaware for that purpose. But then my sophomore year, my mom developed breast cancer, and so that is what really changed my trajectory. And then I chose Baylor College of Medicine for my PhD, where I worked with Jeff Rosen, who is just an incredible breast cancer researcher, but also an amazing mentor. And he's the one who helped me find the Cancer Prevention Fellowship Program because I really wanted to move into a space that was more clinically meaningful. And what was interesting about that is that in Dr. Rosen's lab, I studied both normal mammary gland development and breast cancer. And so it was really gave me a great perspective on the progression from normal to cancer, which is really great when you're thinking about ways to intervene and to prevent cancer in the future. What has been really wonderful in the 15 years that I have been at the NCI is just the immense understanding we have gained in risk factors, as well as the focus on understanding these risk factors across a more diverse population. There's also been incredible innovation in technologies that has led to studies of single cell changes in precancers that help us better understand how to target precancer and to reduce the risk of progression.
Awesome. It's great to hear about, your journey. I'm sorry to hear about your mother. I hope she's doing okay.
She's actually a 20-year survivor at this point.
Congratulations.
She has been treated incredibly well and was lucky that her cancer was low risk.
Yeah. I know it's not always the case for everyone, so I'm happy to hear your mother's doing okay. You shared a little bit about the arc of history you've seen in cancer prevention for breast cancer, but I'm wondering if you could give an overview of the solutions we have today to help women prevent and screen for breast cancer, and what are some of the biggest challenges or barriers we still face in breast cancer prevention?
Absolutely. So breast cancer is really in a unique space. We have 2 FDA approved medications to reduce the risk of breast cancer. Tamoxifen, which is approved for both premenopausal and postmenopausal women, and raloxifene, which is approved in postmenopausal women. In addition, there's been multiple phase 3 trials that have shown that aromatase inhibitors, both exemestane and anastrozole, reduce the risk of breast cancer in postmenopausal women. And these agents have been incorporated into the NCCN guidelines, similarly for the risk reduction of breast cancer. These agents do have toxicities associated with them. And so one of the greatest challenges we currently have is many women don't want to take these agents to prevent or reduce the risk of breast cancer. And so we've been working really hard to understand how these agents could be used in a way to reduce their toxicity, but maintain as much of that efficacy as possible. So there have been studies of low dose tamoxifen, particularly in Italy, that have showed that 5 milligrams of tamoxifen in comparison to the traditional 20 milligram dose can reduce the risk of breast cancer and can have less toxicity. And so that is actually now also incorporated into the NCCN guidelines, where women who are not willing to try the 20 milligram dose can be prescribed the 5 milligram dose to help reduce their risk of cancer. In terms of screening, we have multiple studies ongoing in this space. We have the TMIST trial that is comparing 3D mammography to traditional 2D mammograms, led by Etta Pisano at ECOG Akron, as well as trials focusing on precision screening, such as Wisdom, led by Laura Esserman at UCSF. And Wisdom has some really great basic science embedded within the study, looking at potential targets for risk reduction in different risk groups using 3D organoid models funded through an R01 to an early stage investigator, Jennifer Rosenbluth. These are really key studies, particularly precision screening, which is focused on getting the right screening to the right women, because we don't have infinite healthcare resources. And you hear this debate in the popular press now, because just recently the FDA requirements to report breast density were released. And so there's a lot of interest in understanding what women should get supplemental screening in addition to mammography. And this is a very complicated question to answer, because it's very hard to do a randomized trial of this at this point, because women really want that supplemental screening if they can get it.
Yeah, that's understandable. Speaking of screenings, during the COVID-19 pandemic, we know that a lot of the routine screenings for breast cancer and many other preventable cancers declined. So I'm wondering, how has that impacted breast cancer incidence rates since 2020? And how have NCI and partners like the CDC and cancer advocacy and research organizations worked together to get screenings back up to raise prevention?
Yeah. So you're right. The cancer rates did decline in 2020 due to the reduction in the number of screenings that were being done, because elective procedures were kind of canceled across the healthcare system. And these rates have actually not risen as much as had been expected. And that actually suggests that maybe women have not fully returned to screening. And the rates in 2021 were still slightly below what would have been expected. But there was a concern because there was an increased rate of metastatic breast cancer. So that's breast cancer that has spread throughout the body. And that is really the benefit of screening, is to try and catch it early before it spreads, where the treatment has a lot less toxicity for women, and that way they can continue to have good quality of life even after breast cancer as a survivor. In our work with the CDC and other cancer advocacy groups, it has really benefited from the release of the new U.S. Preventive Services Task Force and the dialogue this created around breast cancer screening. I think just the idea of people talking about it a lot in the press helps remind women that this is something that they need to do. And I know that I am due for my mammogram, and it's actually scheduled for later this month. And I think that's also the benefit of Breast Cancer Awareness Month. Tons of women get screened in October because of that awareness and the idea that it's all in the news, and reminding women to go and get that mammogram.
Of course. Reminder to all our listeners out there that it's not too late to schedule their mammogram if, they're of age and able to. Now, I know that it's one thing to study cancer when people are diagnosed, but it's a total other project to study how we prevent cancer, especially since there's so many factors that contribute to risk, like environmental and lifestyle factors or social determinants of health. So can you share how NCI approaches its study of cancer prevention, particularly for breast cancer?
Absolutely. So what we really think about when we're looking at new ideas to move forward in prevention is a balance between the agent we're studying and the risk in the group in which that agent might potentially have efficacy. And so this creates an opportunity for that risk reduction. So we've been trying to understand who can benefit most from the risk-reducing medications that are approved, like tamoxifen and raloxifene and the aromatase inhibitors. But we've also been studying new agents in higher risk populations, such as BRCA1 mutation carriers, which are at the highest risk for breast cancer due to the genetic mutation. And in this population, we're looking at a drug called denosumab. And denosumab is a monoclonal antibody that is used to treat bone loss in order to reduce the risk of bone fractures in healthy people and reduce new bone growths in cancer patients whose cancer has spread to their bone. But there was some really great preclinical data showing that denosumab could also reduce the risk of developing breast cancer in women carrying this BRCA1 mutation. And so the Alliance has been working with an international group to actually do a 5-year phase 3 risk reduction study to understand how this drug, denosumab, might be able to prevent the risk of breast cancer, particularly in this very high-risk population of BRCA1 carriers. And so the studies are really focused in now trying to look at precision prevention rather than kind of global prevention to target the agents where they really can have the greatest benefit and then also reduce the toxicity overall.
Excellent. I know you've talked about some of the agents, about some of the precision medicine going into cancer prevention, but I was wondering if you could shed some more light on the early phase breast cancer prevention clinical trials grants portfolio that you lead. What are some of the broader goals of the clinical trials, and what strategies or solutions are some of your grantees finding that are promising?
Yeah, absolutely. So I have worked in our early phase breast cancer prevention clinical trials program since I was a cancer prevention fellow. My mentor, Karen Johnson, led this portfolio when I first came to NCI. And it's been an incredible privilege to work with this great team of investigators. We've been really looking at alternate dosing and risk reduction as a way to study these agents. We have also looked at new formulations where the active agents are placed topically rather than taken orally. And we just completed a series of 2 trials with an agent that is 4-hydroxytamoxifen gel. And 4-hydroxytamoxifen is one of the active components of tamoxifen, which is actually a prodrug and has to be metabolized. And so that active metabolite of tamoxifen was placed on the breast. And these studies, actually, women loved participating in them. They didn't want to give the gel back at the end of the study. The idea that something could be applied topically rather than having to take an oral medication every day was really appealing to women. One of those studies was done in women with DCIS before they went to surgery, led by Seema Khan at Northwestern. And unfortunately, that formulation didn't show the efficacy we had hoped. We looked at Ki-67, which is a marker of proliferation in the DCIS at surgery. And we didn't see the same level of reduction in Ki-67 with the gel as we did with the oral tamoxifen. And so, not all of these early phase trials pan out. That's kind of the hallmark of early phase work, but we'll go back to the drawing board, and 4-hydroxytamoxifen is only one of the active metabolites of tamoxifen. And so maybe we need a combination gel product that has both of the active metabolites in it. And so we're thinking about that. The other really exciting work that we've been doing in our early phase program is around vaccines for cancer prevention. And we've studied 2 vaccines in this program, both developed by Nora Desis at the University of Washington. And she has worked with our University of Wisconsin consortia to move both of these agents forward in their clinical development. We recently completed a study with a vaccine called WalkVac, and WalkVac targets HER2, IGFBP3, and IGF-1R. And this vaccine might be interesting in women who have high risk ductal carcinoma in situ, or DCIS. And these women are at the highest risk of recurrence and of new primary breast cancers after their diagnosis with DCIS. And so we're really trying to think about how to target these vaccines to the right population to see that efficacy. Another study that we have ongoing is with a vaccine called StemVac, and StemVac targets 5 stem cell antigens. And this vaccine is currently being studied in women who've completed treatment for triple negative breast cancer, with the idea that in the future, it could potentially prevent triple negative breast cancer. And so we would then move into a population for future studies who are at risk of triple negative breast cancer. And there are some really great new studies looking at AI techniques to understand, just by using a mammogram and AI, who's at risk for triple negative breast cancer. Because one of the challenges we've had in the field is that triple negative breast cancer is really the challenge, other than BRCA1 carriers who are at risk for triple negative breast cancer, but are a very small portion of the population. What are the other risk factors that contribute to risk of triple negative breast cancer. And now with the development of new AI technologies, we really might be able to find that population and create a risk reduction strategy for them.
Those are all really fabulous. I know that we'll get into technology in a bit, but it's amazing hearing that we can think about vaccinations as a tool to prevent breast cancer. I know that HPV vaccines, for instance, are helpful in preventing cervical cancer. So it's really neat to see applications in different types of cancer. I want to pause for a second to talk about cancer occurring in younger people. We've seen incidents of all sorts of cancers happening in adults at younger ages. So do you see this with breast cancer as well? And if so, are any of the clinical trials in your portfolio exploring early onset breast cancer prevention and screening?
Yeah, so breast cancer is rising in younger women, and there's an increasing incidence of breast cancer among women in their 40s, and it's risen 2% annually since 2015. And this is actually part of the reason why the U.S. Preventive Services Task Force updated the guidelines to recommend biennial screening in women age 40 to 74, where their prior guidelines were biennial in 50 to age 74, with the conversation in that age 40 to 50 age range. And there's also been a higher breast cancer death rate among Black women, and that also contributed to this change in guidelines. Many of our trials do focus on younger women. We have multiple studies specifically focused on premenopausal women and preventing breast cancer in that population. However, we don't fully understand the reasons for this increase in the younger age, especially when there's not an underlying family history. And so this is of great interest and a space where NCI is looking to invest in additional research, not just in breast cancer, but across multiple cancers to understand why we're seeing this rise in early onset cancer.
Mm-hmm. Say I am someone approaching my 40s, maybe I'm in the 30s range or in my early 40s, and I know that I have a family history of breast cancer, or maybe I've done some genetic counseling to know that I'm at higher risk. What can those people who are younger but probably don't qualify for the ideal age range for getting a mammogram do to elevate their prevention efforts?
Yeah, so the greatest thing people can do is understand their risk, to know your family history. And there are calculators online. The NCI has a calculator. The Breast Cancer Surveillance Consortium has a calculator. There are calculators where you can put your personal information in, and it will help you understand your own risk. You can also have these conversations with your family physician or with your gynecologist, who are all very qualified to talk to you about your breast cancer risk and help you understand whether or not you should be referred for genetic testing, as you talked about, and whether or not your risk is then elevated to a point where you are then eligible for additional screening beyond these population-based screening guidelines that you see. And so women at very high risk of breast cancer often get MRIs alternating with mammograms every 6 months rather than an annual mammogram due to that very elevated family history.
That's great to know. We'll definitely link to the resources that you mentioned in the show notes for listeners who maybe want to check it out themselves. So I want to talk about technology and cancer prevention for a moment. You wear many hats at NCI, and one of them is the breast cancer and uterine cancer project scientists at the Cancer Intervention and Surveillance Modeling Network. So can you share how simulation modeling and other advanced technologies are also helping us move the needle forward in preventing these cancers in women.
Yes, wonderful. So the Cancer Intervention and Surveillance Modeling Network is known as CISNET, and it has been a great part of my career at the NCI to be part of this group. And I have learned a great deal about the importance of high quality data that is so important for understanding and implementing these models. So what they do is they take different types of data. So we have data from the NCI SEER program that is on cancer incidence and mortality. And we have that data linked to a number of other additional data resources. And then we also have data from the Breast Cancer Surveillance Consortium, where that group had a long-term study of breast cancer screening and understanding how women get screened out in the community. And so that data gives the CISNET modeling group the ability to understand screening intervals. And so they have looked at the benefit of annual screening versus every other year screening versus screening every 3 years. And they have looked at different types of screening. So that consortium also collects data on supplemental screening that women out in the community get. And so they've done studies of supplemental MRI or supplemental ultrasound. And this is something that women are really interested in understanding. What are the benefits of this supplemental screening, especially with the new FDA requirements to report breast density? And so these data are then put together into the model, and that helps us understand what the contribution of different screening has been to our impact on mortality rates and what portion the treatment benefits have been to the decrease that we've seen in mortality. And this model helps us understand kind of the overall picture of breast cancer across the US. There are new technologies that are being added and incorporated as the science evolves. And so this includes AI technologies that we've already talked about, where the risk of breast cancer is being identified off of a mammogram image. And so CISNET is looking to incorporate these new technologies as they evolve, but there has to be enough data available to go into the models. And so that's really the key piece of this, is high quality data to support the modeling.
Of course. I want to take a step back from NCI and look at some of the administration's greater passion and commitment to cancer. We know that President Biden reignited the cancer moonshot in 2022 to reduce cancer mortalities by at least 50% over the next 25 years. And NCI and its partners put together the National Cancer Plan to provide a framework around that larger goal. Prevention is one of the plan's goals. So how do the efforts that you and your team in the Division of Cancer Prevention play in the National Cancer Plan and the President's Cancer Moonshot Initiative?
Yeah, so having preventing cancer as one of the goals of the moonshot is really important for us. And it's also the greatest potential impact on mortality, because if you reduce the cancer's occurrence, you obviously reduce its mortality. And so prevention creates immense opportunity to meet that goal of the 50% reduction. And so we are working across the division and with our early detection colleagues to really hone in on those two key areas of the National Cancer Plan, both preventing cancer and early detection, which we see as combined efforts.
Awesome. I know that we're about to wrap up here. So for our listeners out there, not just women, but men as well, since we know breast cancer can occur in men too, what should they be doing now as we're entering Breast Cancer Awareness Month to maintain their well-being and pursue preventative paths against breast cancer? What can they do now in the next 5 years or in the longer term? And how often should they be getting screened or maybe pursuing some of the preventative solutions that you shared today when they are of age?
Yeah, so I'm just going to go back to the point I made about understanding your own risk. I think this is the greatest thing that an individual person can do. Understanding your personal risk, understanding your family history, particularly for men, which is where a lot of the risk for breast cancer comes from, is from a family history. This can really help you understand and then have conversations with your own physician about your opportunities for risk reduction and your opportunities in terms of screening and how often you should be screened and with what technology you should be screened. And so, I encourage you to go to the NCI website, to use our risk calculators, to talk to your family physician or your gynecologist about your risk and really think about how you should be screened based on your own risk rather than sticking with kind of annual or every 2-year screening, which is not risk-based.
Thank you very much, Brandy. It was such a pleasure to talk to you today, and happy Breast Cancer Awareness Month.
It's been wonderful to get to talk to you about breast cancer. As we start Breast Cancer Awareness Month, it's such a privilege to work at the NCI and champion these efforts. And it's been a great privilege to be here with you. Thank you so much.
I just wanted to stress Dr. Heckman-Stoddard's advice again. Understand your own risk. We've provided links to the risk calculators that Brandy mentioned in the interview, as well as more information that NCI has about breast cancer and its clinical trials, so that you're equipped to take care of your health. I know October and Breast Cancer Awareness Month are just beginning, but before you know it, next month will mark November, and with it, Election Day. And I know, elections come with a lot of different feelings for many of us, elections officials included.
This year's election fills you with
joy,
hope,
excitement.
I feel there should be joy, but there is some angst.
Why?
The biggest thing I worry about is the possibility of violence.
We're daily receiving threats, whether it's through voicemails, emails, social media, or in person.
You personally?
Oh, yes, and it's escalating. And they're all rooted in lies and misinformation, which is always very disappointing and sad, but at the same time, it's real.
So, with a lot of weighted feelings around the election, how are our states and local election boards gearing up for next month's election? We'll explore this very question in your feed on Friday, November 1st, with a timely special episode of Empathy Affect. Joining us will be the chairman of the Election Assistance Commission, who will walk us through how the EAC's been helping election officials nationwide prepare so that we can vote with confidence. Please follow and subscribe so you can stay tuned, and make sure to share the show with a friend. I appreciate you joining us on Empathy Affect, and I hope you listen in again soon. Thanks, y'all.
Empathy Effect is a product of Forrest Marsh. You can reach us at forrestmarshmedia@forrestmarsh.com with any feedback, questions, or inquiries. If you want to know more about today's guest, are interested in participating with Forrest Marsh, or becoming part of our community, check out our show notes for more information.